Hello everyone. Today we are going to discuss about congestive cardiac failure in pediatric age group. We will be going through the following points in congestive cardiac failure: definition, the causes of congestive cardiac failure, clinical presentation, investigations and management. So as you all know, the heart is a pump. What does the pump do? It gets filled in with blood and pumps out. So it delivers nutrients and oxygen to the last cell of the body. That is the function of the heart. So any issues with pumping out or with filling in or a combination of both of these situations can cause what is called as heart failure or failure of the heart to do its function. So definition wise, it's a clinical and pathological syndrome of varied etiology in which the heart is unable to pump enough blood to meet the metabolic needs of the body. And that results in systemic and pulmonary vascular congestions, giving rise to characteristic signs and symptoms, and is associated with circulatory, neurohormonal and molecular abnormalities. Now, for causes of congestive cardiac failure, since the heart is not being able to pump the blood, yes, cardiac causes are there, but then most important again are non-cardiac causes also. So, non-cardiac causes are other systems which have an issue, and that's why the heart is not being able to do its function. Hematological, like severe anemia, can cause congestive cardiac failure. Renal, if you have a severe hypertension due to renovascular cause, it can cause hypertension. Endocrine, again, severe hypertension or thyrotoxicosis can cause congestive cardiac failure. There are many genetic and metabolic causes of congestive cardiac failure which sometimes cause deposition in the heart or in some other blood vessels, and that can give rise to the heart being not able to do its duty. Nutritional causes such as beriberi and again severe anemia due to nutritional causes, it can cause congestive cardiac failure. Rheumatological causes such as SLE and various drugs, toxins, envenomations like snake bite, scorpion bite, they can also cause congestive cardiac failure. So important to remember that not only cardiac but there are non-cardiac causes also. Now coming to the main cardiac causes could be either a structural or acquired causes. Structural is something which is there present since birth, like congenital heart diseases. Acquired are something which are not there at birth, but then they can affect the heart. It could be infection, inflammation, or some deposition in the heart, or some toxins and various causes. So again, heart, cardiac tissues, like every tissue affection can cause different kind of presentation and different type of congestive cardiac failure. So if the involvement is due to endocardium involved, something like an endocarditis, the presentation might be different. Something like a myocardium, then myocarditis or myocardial infection, inflammation, the conditions may be different. Similarly, pericardium, pericarditis, pericardial tamponade, or the vascular supply of the heart, ischemic heart disease, or the conducting system of the heart like tachycardiomyopathies and severe bradycardia. These can cause the heart to not pump properly and the clinical syndrome of congestive cardiac failure. Now, these are just the list of cardiac causes. Congenital heart diseases, they have classified into shunt lesions, obstructive lesions. Now, shunt lesions can be like ventricular septal defects, atrial septal defects, PDA, endocardial cushion defects, and AV malformations. Obstructive lesions could be either outflow obstruction such as aortic atresia or pulmonary atresia, aortic stenosis, pulmonary stenosis, or coarctation of aorta. Inflow obstruction, similarly mitral stenosis called triatriatum or tricuspid stenosis or atresia. There are a few complex heart diseases in which combination of all these things can come, and they might be something called as cyanotic heart disease with single ventricle, such as hypoplastic left heart syndromes or transpositions or single ventricles. These TAPVC, AP window, these are complex congenital heart disease which can give rise to congestive cardiac failure. Acquired heart diseases, as we discussed, it's not only the structural lesions, endocardium, myocardium, blood vessels, the pericardium as well as the conduction system can get involved. So acute hypertension is, yes, due to any cause, due to renovascular or due to endocrine causes, can cause congestive cardiac failure. Arrhythmias, supraventricular tachycardias, complete heart blocks, ventricular tachycardias, all can cause congestive cardiac failure. Inflammatory conditions such as acute rheumatic carditis and chronic rheumatic valvular heart disease are known causes of congestive cardiac failure. They present repeatedly with congestive cardiac failure. Kawasaki disease, if it causes coronary artery disease leading to ischemic myocardial involvement, then can give rise to congestive cardiac failure, or in acute stages sometimes due to the disease inflammation itself can give rise to congestive cardiac failure. Similarly, infective endocarditis or myocarditis with viral, bacterial or parasitic infections. Something we just said, toxic myocarditis like scorpions or scorpion venom or drugs, especially anti-cancer drugs, anti-malignancy drugs have cardiac effects, and they can over the time present as congestive cardiac failure. Dilated cardiomyopathy due to other reasons, or all these inflammatory myocarditis, infective myocarditis can give rise to dilated cardiomyopathy, and then it is a cause of congestive cardiac failure. Similarly, metabolic and endocrine abnormalities, nutritional like beriberi, severe anemia, and sometimes even due to secondary to pulmonary causes like cor pulmonale, in which severe pulmonary artery hypertension can give rise to right heart failure and ultimately biventricular failure. The list was exhaustive, but the commonest causes of heart failure in practice are congenital heart defects. 50 to 65% of all heart failure hospitalizations in pediatric age group are due to congenital heart defects. The second most commonest cause being myocarditis, cardiomyopathies, yes, and then remaining causes of cardiac and non-cardiac causes present as heart failure. Now, there are certain etiologies which can present at certain age groups. So, if depending upon the age of the child and presentation, the timings of congestive cardiac failure might be different. So, if your congestive cardiac failure, if the child presents or the newborn baby presents within the first 24 hours, then most likely there are non-cardiac causes like neonatal asphyxia, hypoglycemia, anemia, hypervolemia, polycythemia, sometimes intrauterine sepsis and hypocalcemia. So, congenital heart defect generally doesn't present within the first 24 hours unless it's like antenatally diagnosed or having that kind of congenital heart defects. From birth to 72 hours, again, yes, cardiac causes come, either outflow obstructions like pulmonary or aortic atheresias, or mitral stenosis, critical stenosis of the aorta, or coarctation of aorta. Extreme heart rate variations like complete heart block or severe tachycardia can present as congestive cardiac failure in the first 72 hours. From 4 days to 1 week, all the congenital heart defects like hypoplastic left heart syndromes, transpositions, those which are we call as duct dependent lesions, duct dependent either pulmonary or the systemic circulation lesions, they present from up to 1 week. From 1 to 4 weeks, the other lesions such as transposition or the similar lesions can present, or coarctation. From 1 to 2 months is the typical presentation of commonest shunt lesions like VSD, PDA and AV canal defects. But yes, then transposition, VSDs and other things also can present at 1 to 2 months. And beyond 2 to 6 months, transposition, malposition complexes and the routine cases also present. So depending upon the age of presentation also, you can make out what causes could be there. Clinical features, symptoms in infants, they present with poor feeding, tachypnea which increases with feeding, poor weight gain, sweating on the forehead during feeding, and something called as a suck cycle. The child tries to feed and then leaves the feed, then cries and again is hungry, so wants to feed again but cannot complete his feed. So it takes a long time for the child to feed. So routinely, if it's a 15-20 minute feed, they take around 1 hour for the feed, and then at the end they are not satisfied with it. So this is something called a suck cycle, which is again very typical of a congestive cardiac failure. In older children like 4-5 years or above, they present as shortness of breath which increases with activity, easy fatigability. They can't cope up with the play with the amount of play their other friends do. They are not able to do that much. They get easily fatigued. Sometimes, very rarely, they present with edema as puffy eyelids and swollen feet, which is very rare. Generally in teenagers and above, sometimes we can get this kind of presentation, and isolated right heart failure, if then only we can get this kind of presentation. So this is typically an infant video of an infant who is having distress. As you can see here, there is I don't know whether you can hear it, but there is audible grunting and subcostal intercostal retraction. So this is how typically a child with congestive cardiac failure presents. Now signs, these are the symptoms. Now signs, due to compensatory response to impaired cardiac function, you have tachycardia, you have gallop rhythm, that is the third heart sound and fourth heart sound come into play. Sometimes you get a weak thready pulse, and again because of increased sympathetic discharge, you get perspiration and cold wet skin. If individual ventricular failure is there, like RV failure, then sometimes you might get hepatomegaly, but then that hepatomegaly, absence of hepatomegaly does not rule out CCF. But yes, if it is there, it can be a sign or a sign of congestive cardiac failure. Again, edema and distended neck veins are seen generally in older children, not in the infants and smaller children. Generally, signs of LV failure are present in pediatric age group. It's either a biventricular failure or mostly LV failure. Isolated RV failure is rare. So children present with tachypnea, dyspnea on exertion, orthopnea, and wheezing and pulmonary crackles. These are the signs which you get on auscultation and on palpation and inspection. Now, how would you approach if a child comes to you with such kind of symptoms? What would be your approach? So, yes, exactly. If you suspect a congestive cardiac failure, the first thing you might want to do is a chest radiograph to see the cardiac size and if there is increased pulmonary vascular blood flow, which can give a rough idea about whether we are dealing with a congestive cardiac failure due to shunt lesions or congenital cardiac diseases. So, this is one of the typical examples of an increased left to right shunt lesion. Left to right shunt lesion with increased pulmonary blood flow. As you can see, the cardiac size is enormously increased and there is pulmonary congestion. All the pulmonary vasculature you can see is severe plethora is there, and if you can get into the abdomen, there is hepatomegaly as well. So these X-ray shows all the signs of congestive cardiac failure. The next thing, yes, ECG is important in cases where you suspect if it's a tachycarrhythmia or bradyarrhythmia, and sometimes it gives a clue of ventricular hypertrophy, and depending upon whether there is ischemia or inflammation. But all in all, unless it is a case of rhythm disorder, an ECG is not of much help. Lab studies, yes, for ruling out other causes such as anemia, severe anemia, renal causes, electrolytes, calcium, thyroid function tests. These studies will tell you non-cardiac causes, and if they are so, then you may need to treat them. Sometimes congenital cardiac lesions can coexist with these kind of other system involvement also, which again from a management point of view is important to know. Yes, echocardiography remains the mainstay of investigation and plan for further management. In pediatric age group, the echocardiography, I mean, the windows are fantastic, so you can get the complete diagnosis only on an echocardiography many a time. So this is just an example of, as you can see, the left ventricle, right ventricle, and there is a large VSD. This is the interventricular septum, and there is a large defect here. And this child, if presents with signs and symptoms of congestive cardiac failure and a murmur, you know you're dealing with a congenital heart disease of increased pulmonary blood flow. This is, again, you can see the whole left ventricle in cross section, it is dilated, and this function, if you can compare this function with this function, the contractility is not good. So this is something called as a dilated cardiomyopathy. Again, either due to myocarditis or post myocarditis, this kind of picture is there, and this children typically present with congestive cardiac failure. This is a cardiomyopathy, hypertrophic cardiomyopathy. This also can present as congestive cardiac failure. You can make out the difference. This is dilated, this is hypertrophied, and again both of them can present as congestive cardiac failure. So the principles of treatment of congestive cardiac failure are as far as possible, specific treatment for the cause. If it's a congenital or otherwise, depending upon the cause, you have to treat that cause if it is treatable. And correction of precipitating factors like anemia, infections, etc. Oxygen, yes, in an acute stage, if the child is in distress, you need to give oxygen. Nutritional support to maintain growth, this generally comes after the child is discharged, and then if the function is very poor, then sometimes you may have to use anticoagulants to prevent intracardiac thrombus formation. Now, this is the interaction of various beneficial and harmful hormonal and neurotransmitter pathways resulting in heart failure. As you can see, a decreased cardiac output causes increased sympathetic tone, angiotensin, many inflammatory markers, and all these things are released. They cause failure to thrive. They again cause cardiac remodeling. The cardiac remodeling, in short term, it is good, but then over a long period of time, it is again leads to decreased cardiac output. A decreased cardiac output causes increased ANP, BNP. These are the neurotransmitters which are released, which again from a pharmacological point of view, if you can block them, then you might have even the treatment part, they are important. The pharmacological treatment, yes, preload reduction with diuretics, afterload reduction with angiotensin converting enzyme inhibitors, inotropes in acute stage to improve cardiac contractility, and then beta blockers also for the compensatory neurohumoral changes which are there. They are important in that point of view. Diet, salt restricted diet in general, not necessarily completely. Water restriction in presence of acute stages and if there is poor renal perfusion. Feed, yes, calories intake for a child in CCF or with congestive cardiac failure and congenital heart disease, you need to increase the calorie content and iron supplementation for anemia. The various drugs which are used, oral digoxin is one of them. Nowadays not so much used, but then yes, in certain conditions only it is used, like chronic congestive cardiac failure with rhythm disturbances. Most important point is the dose differs, and it's a drug with very narrow therapeutic index, so generally nowadays it is not used. Diuretics remain the mainstay. They control the pulmonary and peripheral signs and symptoms of congestion. Thiazides if there is mild heart failure, and loop diuretics for severe failure, but generally by and large what we use is furosemide, and we add a spironolactone with it, an aldosterone antagonist. ACE inhibitors, yes, almost always used for children with CHF, and its dose is titrated to the maximum recommended doses. Commonest one used is enalapril. Captopril nowadays is not available. Beta blockers are becoming, their use is recommended only after stabilization of acute phase, and they are increasingly recognized as an integral part of CHF therapy. Carvedilol is the commonest drug which is used in children. Afterload reduction, sometimes in acute settings you need IV afterload reducers to tide over the crisis, and then that time you might use sodium nitroprusside, nitroglycerin or other inodilators. The normal values of blood pressure are given here. To that level you have to, I mean, you should not cause hypotension, but then yeah, you have to make the blood pressure normotensive. For short-term use of inotropic agents, yes, when do you use inotropes? In acute stage, if there is low cardiac output, poor peripheral perfusion, low blood pressures or signs of end organ dysfunction and severe LV dysfunction, that time you use the drugs used are dopamine, then dobutamine, epinephrine, and after using all these drugs, even then if the child is in congestive cardiac failure and you have now decided that he is not improving drug with your medical management, the further step is device-based therapies for chronic congestive failure, and this is, there are some things called as intra-aortic balloon counterpulsations, cardiac resynchronization therapy, and implantable cardioverter defibrillator. Now intra-aortic balloon pump counterpulsation is you put a balloon in the thoracic descending aorta, and it has a repetitive pneumatic inflammation and deflation of that balloon, which assists in during systole and augmenting the aortic perfusion during diastole. So that is one thing which is used, though less commonly in pediatric age group, but then yeah, in teenagers and older children you can use them. Cardiac resynchronization therapy is again a form of electrophysiological intervention where you put biventricular pacemakers and synchronize them with the, so that the pumping is accurate and the maximum cardiac output is achievable. Something called as mechanical circulatory support is extracorporeal membrane oxygenation. If the child is in acute fulminant myocarditis and you need to rest the heart, that time what you do is the whole function of the heart is supported by a machine. So this is something how a cardiopulmonary bypass machine or an ECMO machine looks like. As you can see, the child is in the upper left corner, and then there are two pipes coming out. One is the venous and one is the arterial, and all the circulation is carried out by the machine outside there. So similarly, this is a huge setup, and there are some things which can make the child ambulatory also, and those are called as left ventricular assist device or artificial hearts or home inotrope infusion pumps. So this is something which an artificial heart looks like, and many times the child can be made ambulatory, and it is nowadays available for pediatric and neonatal age group also. So this is generally a temporary bridge to transplantation, because the final step in management in chronic congestive heart failure, which is not responding to drugs, is heart transplant. So yes, heart transplant in pediatric age group nowadays it is picking up, but not so much so as much as in adults, and not so much so in our country. But yes, within the next 5-10 years the picture might be different. So heart transplant is yes one of the management goals or last goals in management in congestive cardiac failure. So to conclude, non-cardiac causes are also as much as important of cardiac as cardiac causes for cardiac failure. The clinical presentation may be subtle in older children and adolescents, so you have to have a high index of suspicion. Obviously, echocardiography is the mainstay for diagnosis and management. Treatable CHDs or congenital heart diseases have a very good long-term outcome. Cardiomyopathies and myocarditis, they have a prolonged course, they require chronic management, and eventually may or may not reach up to transplant. Yes, having said that, heart transplant is the last, now at present, mostly a theoretical option, but heart transplant in itself is a new disease. So thank you very much.